Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Jim Januzzi, professor of medicine at Harvard Medical School, senior staff cardiologist at the Massachusetts General Hospital, and chief scientific officer at the Baim Institute for Clinical Research in Boston, Massachusetts, here in the United States of America. Welcome to this discussion titled Navigating the New Era of Heart Failure Treatment, Practical Use of Nonsteroidal Mineralocorticoid Receptor Antagonists. It's a big title, big topic, really important. And joining me today is my colleague and a respected friend, Dr. Beekam Boskert. Beekam wears many hats at the Baylor College of Medicine in Houston, Texas. She's a professor of medicine, a dean. She's editor-in-chief of Jack Heart Failure and also one of the leaders of the U.S. Heart Failure Guidelines for the American College of Cardiology, American Heart Association. Beekam, welcome and thanks for joining me. Great. Well, I can think of nobody better to have this discussion today. And we're going to talk about challenges in the current management of individuals with heart failure. We're going to talk really about preserved or mildly reduced ejection fraction. I think it's pretty well established at this point where mineralocorticoid receptor antagonists fit in for reduced, but there's this whole new world of data regarding the newly approved nonsteroidal mineralocorticoid receptor antagonists for HFpEF or mildly reduced EF, how they fit into current treatment algorithms. We'll talk about how to identify the ideal opportunity for nonsteroidal MRA use and where they fit in next to SGLT2 inhibitors. And then lastly, we'll talk about the optimal management of individuals who might be eligible for nonsteroidal MRAs to maximize clinical outcomes. So let's set the scene, right? So, what are the current challenges and unmet needs for these folks? And, for the balance of the discussion, we're going to be talking about people with heart failure and ejection fractions greater than 40%, right? So, those are the real focus today. Mildly reduced ejection fraction, so 40 to 49%, and preserved ejection fraction, 50% or higher. And we'll talk about the rationale for new therapies. And I think that it's pretty clear that these patients have unmet needs. And so let's first start with the status update on the treatment for these individuals and the use of nonsteroidal MRAs. What's the standard of care? Well, it's a challenge, right? We have some good data. I wouldn't say great data historically, but this has all changed. The current guideline recommendations undoubtedly will evolve now that the first FDA-approved nonsteroidal mineralocorticoid receptor antagonist has hit the scene for individuals with an EF greater than or equal to 40%. How did we get here? Well, we knew from predicate data that there might be a signal of benefit from steroidal MRAs. In particular, there were data looking at the value of spironolactone in these individuals. The TopCat trial, which was a study of nearly 3,500 global participants, randomized individuals with heart failure and preserved and mildly reduced EF to receive spironolactone versus placebo for an average of around 3 years. As is well known probably to the viewers, the overall performance of spironolactone in this study was close but not statistically significant to reduce cardiovascular death, heart failure hospitalization with an 11% reduction overall. And it really was driven largely by heart failure hospitalization, which was reduced, but was not considered a co-primary endpoint. So the overall outcome was neutral. So the observation of a reduction in heart failure hospitalization is really more hypothesis generating. Now, with that in mind, and keeping in mind that the potential benefits of spironolactone are hypothesis generating only, there were some post hoc observations. The first of which was overall, individuals with modestly elevated natriuretic peptides seemed to have some benefit actually for the primary endpoint. As well, there was this really curious interaction with EF and sex. Specifically, among people with ejection fractions in the mildly reduced category, there seemed to be benefit, whether male or female. But in particular, women had benefit across the whole ejection fraction spectrum, whereas it was men who lost the benefits of spironolactone at or above an ejection fraction of 55 to 60%. So this sex by treatment interaction, which we've seen with other therapies, showed itself with spironolactone as well. In addition, as I'm sure many recognize, the story with spironolactone and Topcat became even more complicated when sub-analyses looking at study participants enrolled in the Americas versus Russia and Georgia had grossly divergent outcomes, as well as a potentially different response to spironolactone relative to treatment efficacy to reduce events. So specifically, study participants enrolled in the Americas had much higher event rates, more consistent with a true heart failure population. And furthermore, there was a statistically significant reduction in the primary outcome and both cardiovascular death and heart failure hospitalization from spironolactone. But both of those findings, again, are hypothesis generating only, because of the fact that they were post hoc findings. And so that left us rather with an overall neutral result. But times have changed now, and we now have data with a non-steroidal MRA, finerenone, for individuals with heart failure and mildly reduced and preserved EF. And I'm going to ask Dr. Boskert now to tell us a bit about the clinical trial that led not only to our first successful trial in this patient population with MRAs, but also that led to regulatory approval for the therapy.
Thank you, Jim, for setting the stage. The name of the trial that is providing that paradigm shift is Fine Arts, which enrolled symptomatic heart failure patients either in the ambulatory or hospitalized setting with ejection fraction over 40%, which includes patients with mildly reduced and preserved EF. These patients also had evidence of structural abnormalities in the heart and elevated natriuretic peptides. The exclusion criteria included patients with hyperkalemia at baseline with potassium levels over 5 or EGFR less than 25. Importantly, this study demonstrated safety and efficacy with nonsteroidal MRA, specifically finerenone, with evidence of reduction in the primary combined endpoint of cardiovascular death and heart failure hospitalization. The risk reduction was somewhere around at the range of 16% on top of background therapy. Um, it equates to almost 3 years of event free survival gain for an individual over age 55. So, this is substantive improvement on background therapy. And overall, this therapy was well tolerated. The serious adverse events with finerenone was comparable to placebo. There were higher incidents of hyperkalemia, either as measured in the serum or by investigator reporting. But the hyperkalemia leading to hospitalization was comparable to placebo. It was not higher than the placebo rates. There were no hyperkalemia events leading to death. And importantly, there were lesser incidents of hypokalemia with finerenone when compared to placebo. And importantly, as I mentioned, this therapy was effective on top of background therapy. And one may wonder, does it work even amongst those individuals who are already treated with SGLT2 inhibitors, which currently have a class 1 recommendation in patients with heart failure with mildly reduced and preserved EF? And the answer is yes. By subgroup analysis, there was no heterogeneity, i.e., no difference in the efficacy of nonsteroidal MRA according to use or not use with SGLT2 inhibitors. There was evidence of benefit amongst individuals who were already on SGLT2 inhibitors. Thus, the add on concept with nonsteroidal MRA on top of SGLT2 inhibition in patients with mildly preserved and mildly reduced and preserved ejection fraction is quite effective. And overall, I think the fine art solidified the extension of the indication to the heart failure population with mildly reduced and preserved EF.
Really, what a brilliant summary, Beacom. Thank you for that. And it sets the important stage for, I think, more discussion about similarities and differences from what we knew about spironolactone, as well as understanding key topics like safety and the value of the therapies relative to each other. So why don't we start first about key differences between, say, Top Cat and Fine Arts, but maybe even more generally, steroidal and nonsteroidal MRAs in particular.
Thank you, Jim. The first concept that I would like to touch on with the steroidal MRA, as you demonstrated, there is attenuation of benefit by subgroup analysis as the EF gets higher. So we seem to have a ceiling effect with the steroidal MRA, at least by the data that we have seen in TopCat. The benefit seems to be higher at the lower EF spectrum with steroidal MRA. Other agents such as ARBs as well as ARNI had the same finding by post hoc analyses from the trials, demonstrating attenuation of benefit from ARBs and ARNI with a higher EF. We don't see that with nonsteroidal MRA. By subgroup analysis according to EF, there was no heterogeneity in the efficacy of finerenone. There was equal benefit in individuals with EF in the mildly reduced, normal EF between 50 to 60, or EF higher than 60%. And when we look at the overall association across the spectrum of EF with the endpoints, it looked like there was equal benefit across the EF spectrum. So that's one of the first features. The second feature difference is mechanistically, we need to be aware of the properties of nonsteroidal versus steroidal MRA. Nonsteroidal MRA has a higher potency and selectivity to mineralocorticoid receptor, and resulting in a shorter half life and is not metabolized to active metabolites. And thus, the side effect profile, especially with gynecomastia and other side effect profile, is lesser compared to the steroidal MRA. There's also another important feature. There appears to be a more balanced kidney and heart tissue distribution. This is one of the hypothesized mechanisms of potential benefit beyond the heart, such as the kidneys. And for that reason, I think it would be important for us to review the evidence of benefit with nonsteroidal MRA in other populations than heart failure. And we do have very robust data, especially in patients with diabetes and chronic kidney disease. And I would like to mention a few studies. The first one is the Fidelio DKD study that recruited patients with diabetes and chronic kidney disease. And also the Fidelio trial, which again recruited patients with diabetes and chronic kidney disease. And these two studies looked hand in hand in endpoints that are important both for the nephrologists, cardiologists, and general practitioners. In the Fidelio DKD trial, the treatment with finerenone resulted in significant reduction in progression of kidney disease. So the kidney failure, sustained 40% decrease in eGFR from baseline, or renal death or requirement for dialysis was significantly reduced in patients with diabetes and chronic kidney disease in Fidelio DKD trial. In Figaro DKD trial, in patients with diabetes and CKD, there was a significant reduction in composite cardiovascular death, myocardial infarction, stroke, and heart failure hospitalizations. And there was a pooled analysis called the Fidelity demonstrating, solidifying the findings of reduction in progression of kidney disease as well as cardiovascular endpoint with nonsteroidal MRA in patients with diabetes and chronic kidney disease. So these studies helped us recognize that nonsteroidal MRA is quite effective in preventing renal outcomes in diabetic kidney disease and was incorporated in diabetes guidelines along with RAS inhibitors and SGLT2 inhibitors as a foundational therapy to prevent progression of kidney disease in patients with diabetes and chronic kidney disease. And with the recognition from the pooled analysis of Fidelity demonstrating reduction in cardiovascular death and heart failure hospitalizations, which was predominantly due to reduction in heart failure hospitalizations. This agent was recognized as an agent that was helpful in prevention of heart failure in patients with diabetes and kidney disease and were incorporated in the European Society of Cardiology heart failure guidelines as an agent that is recommended to prevent heart failure hospitalization in patients with type 2 diabetes and chronic kidney disease. Another third feature that I think is different between steroidal and nonsteroidal MRA is the current evidence in terms of the metabolic profile. We do have pre-specified analysis from Fine Arts trial demonstrating that nonsteroidal MRA is helpful in prevention of new onset diabetes in patients with heart failure with preserved EF. This is very important because we had not seen that kind of a data with steroidal MRA with spironolactone in the former studies. It looks like in the Fine Arts trial, in individuals who did not have baseline evidence of diabetes, the onset of diabetes was reduced, and the efficacy of benefit with nonsteroidal MRA was not different. It was equally effective amongst individuals with or without diabetes. What I would like to do now is positioning the evidence and trying to determine whether we could see how to implement this in clinical practice. And I'd like to review a case study. Let's go over a classic patient that usually presents with decompensated heart failure with preserved EF to the hospital. So our case is a 64-year-old female admitted to the hospital with new onset acute decompensated heart failure with symptoms of shortness of breath, fluid retention with more than 10-pound weight gain over 2 weeks, evidence of edema, no evidence of acute coronary syndrome. The patient does have comorbidities of diabetes and hypertension, has been treated with SGLT2 inhibition, empagliflozin, at a dose that was prescribed for diabetes at a 25 milligram daily dose. Hemodynamically stable, good blood pressure of 120/70, good heart rate, has evidence of fluid retention with elevated jugular venous distension, bibasilar wells, 2+ ankle edema, elevated natriuretic peptide levels, eGFR of 51, a little bit of a hypokalemia, 3.4 at presentation. Echo reveals preserved EF, normal wall motion, normal chamber sizes, except for enlargement of the left atrium, and evidence of elevated filling pressures, no structural abnormalities in terms of the valvular abnormalities, and chest X-ray reveals pulmonary congestion and is initiated on IV diuretics with loop diuretics, diuresis effectively, 12 pounds over 2 days with resolution of dyspnea, edema, RALS, and JVD. No evidence of acute ischemia by nuclear stress tests, and the telemonitor does not reveal any evidence of arrhythmia. Continued on the SGLT2 inhibitors, initiated on finerenone 10 milligram daily with a plan to increase it to 20 milligrams, and the IV furosemide switched to oral furosemide 40 milligram twice daily dose. So, in this context of this case, Jim, want to ask you about how do you envision nonsteroidal MRAs to be integrated into the current treatment paradigms
Sure. Yeah.
alongside the SGLT2 inhibitors?
Absolutely. Yeah. A great point. And that really gets right to the heart of the discussion, which is implementation of guideline directed medical therapies, approved medical therapies. One of the immediate questions I had in listening to this case is whether we had a UACR available for this lady, because knowing that she had proteinuria would add yet another layer of indication for finerenone. But this is someone who fits in very well, actually, with the benefits of nonsteroidal MRA use, and I'll tell you why. I mean, the first thing is if we just take a step back and ask how might nonsteroidal MRAs fit into the current established treatment paradigm. We can look at the US heart failure guidelines, the American College of Cardiology, heart failure with preserved or mildly reduced ejection fraction, expert consensus decision pathway recommendations. Both actually have MRAs embedded within because clearly, unlike spironolactone, we have evidence from clinical trials of benefit for finerenone in this context. Now, um, one of the things that we did when we put together the expert consensus decision pathway document was we put therapies side by side. They are equals among each other when we look at the various therapies. And in that context, the question comes up, should we use one or both? And the answer clearly is to use both together. In the fine arts analysis, there was no interaction by the presence or absence of SGLT2 inhibitor use. And when you look at the combination of the two, it seems quite clear to be a disease modifying strategy with significant reduction in all of the various outcomes in those treated with SGLT2 inhibition. What's interesting is that in using SGLT2 inhibitors together with MRAs, there's been this emerging observation. It's not really a hypothesis. We've seen it both in clinical trials as well as in clinical practice that use of SGLT2 inhibitors and MRAs together has a really unique effect on the complications of MRA therapy, specifically the frequency of hyperkalemia. Now, this is a complicated topic, but the confidence trial recently reported data that I think are pretty illustrative of the effect when you combine the two therapies. And, try to follow me on this one for the viewers. When you combine an MRA, a nonsteroidal MRA, plus an SGLT2 inhibitor, the overall change in serum potassium may be slightly higher than if you use either drug alone. And many clinicians might say, well, wait a minute. I've been told that using the two drugs prevents hyperkalemia. What we saw in the Emperor program, as well as what was seen in Confidence, is that although the overall change in potassium was slightly higher with the combination, the frequency of severe hyperkalemia, a potassium of 5.5, a potassium of 6 or greater, was lower with the combination. So, although you do see an upward rise in potassium from the combination, the risk for severe complications is substantially lower. So, it's important to recognize there's benefit and safety from the combination.
Thank you, Jim. You touched on this, especially in terms of the location by where this therapy could be initiated. When do you think is the ideal opportunity to initiate a non-steroidal MRAs? Hospital setting, outpatient setting?
Yeah, great question. Well, I coordinate our GDMT clinic at Mass General Hospital. And the answer to start with is, given the gaps in GDMT that exist, the answer is anytime you recognize that a person is eligible. However, there are predicate data to suggest that the benefits of finerenone are particularly strong among those individuals who've been recently hospitalized. So, subgroup analyses from the Fine Arts HF trial would suggest that patients such as the one you described in your case got particularly clear benefits with a significantly lower rate of events, as well as a lower with a greater benefit in terms of the incident or incidence rate of cardiovascular death and heart failure hospitalization. So for those reasons, I'd say anytime the gaps are present, but particularly in those patients after hospitalization. And you and I are participating in a clinical trial called. Now, I'm going to turn around and ask you a question, Beek. When you're starting a nonsteroidal MRA, what sort of baseline assessments would you perform? Let's say you're seeing that patient in the hospital or in the post-discharge clinic.
Most importantly, we would like to assess the baseline kidney function and eGFR with the creatinine, and also the potassium for the safety and being aware of the indications and the exclusions for the patient population recruited to the Fine Arts trial. So the baseline potassium as well as the eGFR would be the minimum assessment that I would do. Of course, we do as heart failure clinicians do a battery of tests. First of all, we assess the patient, making sure that they do have heart failure with preserve, which entails doing an echocardiogram at baseline, making sure that they have a comprehensive evaluation to ascertain the diagnosis, and we do obtain natriuretic peptides to help us affirm the diagnosis as well as it's a good prognosticator. So the overall clinical assessment for heart failure is important. But along with that, for these agents, for nonsteroidal MRA, I'd like to emphasize that obtaining the baseline potassium levels and the kidney function, creatinine is important, and eGFR calculation is important.
Super. And do you adjust the dose based on the eGFR, for example?
Yes, and our initial dose for eGFR greater than 60 for finerenone allows us to start at a 20 milligram and increase it to 40 milligrams. When eGFR, as was the situation in our case, is less than 60, we start at a 10 milligram dose and are able to increase it to 20 milligrams. So for our case, this patient was started on 10 milligrams because her eGFR was less than 60. And in the fine arts, if we examine the protocol, the potassium and eGFR were checked at approximately 1 month after initiation, then every 3 months during the first year, then every 4 months after the first year. But of course, there are always unique circumstances which may warrant an earlier check or a different kind of a follow up. Those individuals who are prone to hyperkalemia, patients with diabetes, advanced kidney disease with concomitant medications may require an earlier follow up potassium check. And then individuals who are with those risk factors may require more frequent checks. But overall, keep in mind, fine arts recruited patients with heart failure with mildly reduced and preserved EF. With this baseline standard protocol, they actually showed a very favorable safety profile when the eGFR and the potassium was checked at baseline, then at 1 month, and then every 3 months. Um, Question for you. What are the considerations for dosing, Jim, from your perspective?
Yeah, it really is about fitting the dose to the patient to minimize the risk for safety issues. And so, when dosed appropriately and with the proper monitoring that you mentioned, which is the same recommendation to some extent as given to the management of spironolactone, at least in terms of the monitoring frequency, we can expect that treatment with finerenone can be quite successful, safe, and well tolerated. You mentioned earlier, of course, and it's important to come back to this, that potassium concentrations do rise when treated with finerenone, but particularly when combined with SGLT2 inhibitors, the frequency of severe hyperkalemia would be expected to be attenuated, but nonetheless requires monitoring. You need to watch serum creatinine levels. EGFR may drop with use of an MRA. This is very rapidly reversible with discontinuation of the medication. But importantly, I want to reemphasize, as you already pointed out, the benefits of finerenone to protect kidney function decline over time. So clinicians should not overreact to a decline in EGFR after starting a nonsteroidal MRA. And importantly, these adverse events, which are expected in some cases, do not lead to hospitalization or death. And so there's the opportunity, provided patients are monitored closely, for clinicians to make the kind of changes that need to be made in order to safely and effectively deploy this really valuable therapy.
And I guess from the perspective of dosing adjustment, in addition to EGFR, we do also in the fine arts, we had guidance of dose adjustment according to potassium levels. Um, for example, the dosing was adjusted with the subsequent potassium levels. There was a recommendation for dose reduction if the potassium exceeded that of 5.5, and discontinuation if the potassium increased to over 6. But up titration was recommended if the potassium was less than 5. So the serum potassium in EGFR, in essence, is a guidance for the initial dose initiation as well as the up titration. Do keep in mind that by the FDA approval guidance, the package insert, finerenone is not recommended to be initiated if the baseline potassium is over 5. Um, the guidance also recommends potassium to be monitored periodically and the dose to be adjusted accordingly. And do be aware of the high risk patients where hyperkalemia may be a higher risk, such as individuals with chronic kidney disease, patients with diabetes, patients on concomitant medication that may reduce the metabolism of nonsteroidal MRA, especially the CYP3A4 inhibitors. And also, nonsteroidal MRA is not recommended in patients with eGFR less than 25 at baseline, or individuals with severe hepatic impairment or during lactation. The other things that I would like to emphasize is by subgroup analyses, there is evidence of safety and efficacy across all age groups. Sometimes the clinicians worry about what about the older individuals, the elderly? Um, by subgroup analyses, safety was evident across all age groups, be it between ages 40 to 66, over 65, or over even age over 80. And thus, the efficacy is evident across all age groups. And importantly, safety was also evident with no heterogeneity according to the age subgroups in the fine arts trial, which demonstrates good safety profile as well as efficacy profile across the spectrum of patient subgroups. We did touch on the adverse side effects from treatment. Um, what adverse events should the clinicians need to be aware of, Jim?
Yeah, so we've discussed the hyperkalemia and EGFR issues. Really, finerenone is otherwise very well tolerated. It does not come with the issues with gynecomastia that steroidal MRAs come with. So that is something that is fortunately not an issue. One of the questions that gets asked is whether adding finerenone might be associated with the risk for hypotension. Certainly among our patients who have hypertension, mineralocorticoid receptor antagonists are excellent antihypertensives. But what's really interesting is that in heart failure, we really don't see, a substantial impact on blood pressure. It's one of the therapies we often use in people whose blood pressures are on the lower side. To be sure, the incidence of blood pressure, systolic blood pressure less than 100 was slightly more common among those treated with finerenone versus placebo in the fine arts trial, but the incidence of systolic blood pressure below 100 with symptoms was not. So we can expect a potential effect on blood pressure, but not to the point of limiting our ability to continue the therapy. And so it really leads to the points that have been made already, which is the need for excellent follow up and monitoring of electrolytes, kidney function, symptoms, blood pressure. If well deployed in that manner, we can expect significant benefit. One of the interesting things that I think can be taken away from the current package insert for finerenone also is the fact that you can actually start this medication with a potassium up to 5. And in our hands in the GDMT clinic, we often see individuals who are deprived of MRA therapy because their potassiums are averaging, say, 4.5, 4.7. Um, that is something that really should be put aside. I'm curious to hear your thoughts on that, Beacom.
I fully agree with you. And keep in mind that a significant proportion of our patients now with these concomitant medications are seeing that bump in creatinine, which actually is not an evidence of adverse event, and if anything, could even imply efficacy of therapy. So RAS inhibition, as well as SGLT2 inhibition, as well as non-steroidal MRAs, now are showing that bump. That's not to say that there's worsening of kidney function in the long run with non-steroidal MRA and SGLT2 inhibition. We have actually kidney benefit, renal preservation effects. So in the whole spectrum, when the eGFR is with that bump of decline and a potassium on that high end, which is the 4.5 to 5 range, there is evidence of efficacy with these agents, and we should not do a disservice of inappropriate discontinuation because in the practice, we do see a lot of reflex approaches of discontinuation, and there is evidence from former studies discontinuation of GDMT is associated with worse outcomes in heart failure with reduced as well as preserved EF. So my answer to you is yes, I do agree. In that range, there is evidence of safety and efficacy, and it is recommended to be initiated and continued.
Thanks so much, Beacom. You and I are both passionate about GDMT, about closing the gaps in care. And this is definitely a great summary that really focuses on the need for good follow up, but good, excellent prescription of therapies that reduce risk. So, why don't you take it home and sum up the discussion for today?
Thank you, Jim. So, in this session, we reviewed the evidence that prompted the FDA to approve the nonsteroidal MRA for heart failure indications. I'm going to go over those two indications. Nonsteroidal MRA is a second class of medications after SGLT2 inhibitors approved for the treatment of patients with heart failure with mildly reduced as well as preserved EF with evidence of reduction of cardiovascular death and heart failure events. So that's the heart failure indication. We did have also, with the former studies carried out in patients with diabetes and chronic kidney disease, that nonsteroidal MRA reduces the risk of progression of kidney failure, the sustained eGFR decline, development of end-stage kidney disease, along with cardiovascular risk reduction, reduction in myocardial infarction and heart failure hospitalization in patients with diabetes and chronic kidney disease. So the indications by the FDA are heart failure and diabetic kidney disease. And these are sometimes overlapping populations, sometimes different populations. One needs to be aware of both of these indications. Keep in mind, nonsteroidal MRA selectively and potently blocks the mineralocorticoid receptor activation in the heart and the kidneys. It is well tolerated, but patients need to be monitored for hyperkalemia and kidney function. So, with that, I think we have come to the conclusion of our session. I would like to thank all of our participants, my chair, Jim, for this wonderful session, and look forward to the future sessions. Thank you. And please do continue on to answer the questions that follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.